Welcome everybody to the latest seminar from 42 Bedford Row, which is called Demystifying Factitious Illness in Care Proceedings. This discussion is presented this evening by two members of Chambers. Tina Cook, our head of Chambers, who is described as having an extraordinary forensic mind and a joy to instruct. She's also a joy to have as a head of Chambers, I can say. She is a family law specialist of many years' experience, as is Sharan Bhachu, who many of you will recognise from other talks. Sharan is a very senior junior in Chambers, incredibly experienced in the most complex cases of care cases and child abuse. And she has, of course, co-presented the brilliant series we've had quite recently on parental alienation. Without further ado, I'm going to hand over to Sharan and Tina to introduce their discussion. But as usual in these talks, we're going to try and find time for some questions at the end. So if any of you, any questions arise during the course of the talk, please put them on the QA tab, and we'll try and field them at the end of the talk. Otherwise, enjoy the talk. Thank you, Sharan.
Unmute, Sharan.
There we are. I'm on mute. Thank you, Tina. Good evening, everyone who has joined us for today's discussion. The purpose of our discussion tonight is to look at factitious illness in a little bit more detail. Factitious illness, or as it was previously known as Munchausen's, and we'll talk about that in a little bit more detail later, can strike fear into the heart of many advocates and legal representatives. We hope today's discussion will demystify and simplify some of the factors to look at, regardless of who you are representing within such cases. Can I first of all start off with a very simple definition of factitious illness? It's a disorder or a condition in which a person without malingering motive acts as if they have an illness by deliberately producing, feigning, or exaggerating symptoms purely to attain for themselves or for another, and this is the important part, a patient's role. People with a factitious disorder may produce symptoms by contaminating urine samples, taking hallucinogenics, injecting fetal material to produce abscesses, and similar behaviour. And we'll talk a little bit about some of the cases that we have done in relation to those. Tina, can I ask you to help us? How does that fit into the terms that we often hear banded around, Munchausen's or Munchausen's by proxy?
It's complicated and it's scary. It's scary for a junior practitioner. It very much depends whether you're, I always say this, whether you're prosecuting or defending as to how you interpret what we're saying. But can I just commend to everybody the Royal College of Paediatrics and Child Health Guidance, Fabricated or Induced Illness by Carers, FII, a practical guide for paediatricians. Published in October 2009. When I looked today, I saw it was reviewed in 2013, but not updated. We learned today that there was probably an update or further information coming out from the Royal College today. So I mentioned it before I answer the question, because it's one of those few documents that I have saved on my desktop, because it is a wonderfully written, although it's quite historic now, idiot's guide. So when I'm giving you definitions, these are my interpretations, but the go-to document is that document. Google it, Royal College of Paediatricians, FII, and it will pop up and you can download it for free. So factitious illness in itself is when one causes illness to oneself. Factitious illness by proxy is causing it to another person. The relevant other person in this case, in our lecture, is a young person under 16. It's important to look at it in our context because it can lead to death, it can lead to physical harm, and it can lead to emotional harm. The emotional harm part is often left out and ignored. But let's have a look at what factitious illness by proxy is. It's where a person, as Sharan says, deliberately produces, feigns, or exaggerates symptoms of illness in somebody in their care. It's incredibly varied. It's not really known why it's done. It's clearly a psychiatric, psychological illness. It's not known whether it's to gain attention, or for some other psychological benefit. We're going to give you a little bit of a discourse about our experience of it, because it is very varied, but it's distinguished from somatization. Somatization is more defined as somebody who genuinely thinks they have the symptoms and pain and illness, whereas FII, whether it's FII itself or by proxy, is somebody who feigns, exaggerates, or induces. So they're two separate things. As far as we're concerned, when we go to court, whether we're prosecuting or defending, it really merges into one, because you don't know whether somebody genuinely feels their child has these symptoms, or whether they are inducing it, or in some way causing it to be exaggerated or fabricated. So it's complicated. It's complicated for a lawyer. It's complicated, I think, for the medics, but it's complicated certainly for the lawyer. Can I just go back up to that emotional harm? We think of it as death or near-death experiences. We think of it as physical harm to a child, but the emotional harm is overlooked. It's really understated. If you, for example, are hospitalizing a child or causing them to think they can't walk and they have to be in a wheelchair and isolating them from their friends, there's a huge emotional impact and element to that. So as far as we're concerned, and I suppose particularly if you're prosecuting, if you're a local authority or a medic, that is something that I think you should be looking at. It's not a bolt-on to your schedule, but it's a really key component part.
Yeah, I'd certainly echo that, Tina. Having represented local authorities in the early stages, it's really important, isn't it, to take stock and give some really serious consideration as to how you plead and what findings you are seeking.
Completely, and really difficult, because the nature of these cases, as we all know, is they are huge. Whether you're prosecuting or defending, it matters not. You will be handed, usually, because the nature of the beast is that the carer is repeatedly going to hospital, repeatedly going to different doctors, repeatedly seeking medical attention, repeatedly bringing the child to the attention of the medics. Hundreds and sometimes tens of thousands of pages of records. And as a trial counsel, you have to go through this, and you really do have to go through all of those. Sometimes it's a joy, sometimes it's a pain in the bottom, but you have to go through all of those and work out, is this FII? Is it somatization? Is it just an anxious parent? So there's a huge spectrum, but it's jolly hard work. These cases are really hard work. These cases are very, very difficult.
And what's really telling is when you do look at the medical documents in more detail, and you prepare a proper chronology, Tina, you will know how much clearer the picture becomes, one way or another.
One of the things I was going to discuss is really what the process should be. Very often these cases start with the medics because of the nature of the beast. They start with the medics. And the medics should be following the document I've commended to you at the very outset. And there should be one designated consultant paediatrician, usually the paediatrician who is caring for the child anyway, but it doesn't always work like that. And a key component of this is a medical chronology. I know, Sharan, you and I do our own chronologies because that's what we do. That's how we prepare our case, especially when they're as big as this. You have to know where everything is. You have to know what the pagination is. You have to know where you can go back and find it. But the medics should really be doing a medical chronology, because it is that medical chronology. It is that working out, do I have an anxious parent here? Or do I have a fabricator or an inducer? So that medical chronology, I mean, I'm afraid to say you don't often see them. I don't often get them. If I'm acting for a parent, the Royal College of Paediatricians or Paediatrics and Health guidance is a very good source of cross-examination, because it's not complied with. And there's lots of reasons for that. I'm not being critical at all. It's a very time-consuming, risky differential diagnosis. To put FII in your differential diagnosis takes a brave or insightful medic. And we've all seen cases where a nurse says, "Oh, just something about this mother, this father didn't ring true, or I just felt the need to test for example, alcohol poisoning in a 6-week-old baby, and lo and behold, it's there. So the chronology is super, super important before it even gets to us, before it even gets to the lawyers.
Yeah. Tina, I just wanted to take you back a little bit because these are very difficult cases, and it is really important to think very carefully at the very beginning and to try and tackle it by looking and considering. But one of the terms that I'd referred to in the definition that I gave at the beginning was malingering.
Yeah.
And I just wanted to talk a little bit about what that actually means and how that fits in with the overall picture, because it's a different condition, isn't it?
Different entirely, I think. Malingering, purposeful faking of symptoms, deceiving the medics for some other purpose. The most obvious one, I suppose, is state benefits. But there might be any number of reasons. It might be to procure a different result in a private law hearing, to stop contact from happening, a deliberate and conscious, purposeful attempt at deception for a tangible, rational, understandable reason, entirely different from that psychological, patient-seeking role that FII and somatization pertains to.
And it's very easy, isn't it, if you're not careful and if you don't look at things with a fine-tooth comb as soon as you can, to confuse the two, because it may not be as obvious.
Oh, it's profoundly difficult. It's profoundly difficult. And one of the interesting things, and I in fact, Sharan and I, the case you and I did in Reading, which is reported, in fact, the expert, the single joint expert paediatrician, there's a wonderful table in the document I keep referring to. Thank you very much, Royal College of Paediatrics and Child Health. There's a wonderful table that sets out the range, the band, the spectrum. And it's spectrum from really anxious new parent who has a sick child who doesn't know what to do about it and keeps asking questions and Googles everything, to somebody who's prepared to put menstrual blood in a nappy. There's a huge range, and they go through that. It's a lovely table. Beautiful table's probably a bit sad and legalistic and anal, but it's a great table because it gives you the range and the spectrum and where people lie. And it's very difficult to work out. It's difficult for the medics, it's difficult for us, it's difficult for judges to work out where on that spectrum. And Sharan, the case you and I did in Reading, the single joint expert had used that table really to define whether or not our client, sadly, at what point they fell on that spectrum. And then it is a useful tool, and it's difficult to call, just very difficult to call.
It is. I just wanted to mention a case that I did last year. In fact, the fact finding was the year before, but with COVID delays, welfare wasn't until last summer. But that was a case which the local authority didn't plead FII, although I had to cross-examine the expert about it, because this was a mother who had repeatedly taken her 7-8-year-old daughter for medical examinations of her private parts because she was convinced that she had been sexually abused. 23, I think, examinations before somebody raised alarm bells, and they were then stopped. But it was difficult because the expert instructed wasn't instructed with any view as to whether FII was involved or not. When I came on board, it became clear to me that this was something that needed to be tackled, and it caused real difficulties because the expert wasn't prepared, hadn't thought about the issues, and yet it was a really important part of why this mother was behaving the way that she was. So it is important to really, really consider as early as possible.
But I think when we come to cases, I can think of lots of cases I've done. There was a very big one last week, a toxicology case where a 3-year-old died. It's all on Bailey and all reported in the press. A 3-year-old dies of cocaine poisoning. And when we come to this mammoth set of papers and we look at it, we are so way down the line from the medics, and we look at it with our experienced eye and say, oh my golly, oh yes, this mother, what? I've looked at the medical records, look what this mother was doing, or this father, look what they were doing. And hadn't you thought, local authority, about FII? Of course, we're usually for the parents, so we don't say that. But it's really very obvious when you have done cases like this. When back to three main obvious points, Sharan. It's fabrication, falsification, or inducement. So if you're reading a set of medical records and there's peculiarities, you and I go, oh yes, that's very new. Isn't it interesting how the child always collapses at the handover of the nursing shifts? There's nobody there. Isn't it interesting how the teat in that bottle managed to fracture and the milk spewed down the child's throat, who apparently had feeding it? There's all sorts of alarm bells. So you're right, really tricky. You come to it, and it's whether it's a consultant pediatrician or you and I, or the lawyer, it's picking up those tiny threads, which on their own, I've often been in a case where somebody else has said to me, I think we should keep that in the pleading because it's really significant. And I say, really? Do we need to? Are you sure? And and then the judge picks on it and says, oh, it's so important because they did this or they did that. So it's putting together that jigsaw that you don't ordinarily see. Fabrication, falsification, and inducing an illness in a child. And because the examples are so varied, and I know we're going to come to that, it's very difficult to say this is or this isn't. No substitute for throwing your papers at trial counsel and saying, go through them all. It's a horrible but fun job, actually, but it takes an awful long time. But you need to do that entire job to see the little pieces of the jigsaw.
Yeah, absolutely. I wholeheartedly endorse that. The bigger picture can only be seen when you've really know your papers and know and put that picture together slowly, piece by piece. Tina, often, and when we come on to talk about some of the examples that we've both and other members of Chambers have dealt with, it's always the child who is the person who is by proxy, effectively.
Yeah.
But that's not always the case, is it? Certainly, I've done a much smaller number of cases where, in fact, it's factitious illness. It's the parent who is causing the illness to themselves, exaggerating, feigning, and that in itself causes significant harm to the child.
Yeah, and because the child lives in a medicalized environment, or the child is at direct risk. I did a horrible case where the mother was doing things to herself, and the child is exposed to it. The mother was doing things to herself and could not walk and could not was not mobile, to the extent that she fell on top of and suffocated the baby. I mean, that's an extreme example, but that's a death situation. But the emotional torment of a child in that over medical, it's back to the environment. It's the emotional harm, isn't it? Yeah. That over medicalized environment, the exposing a child to your own illness, to your own fears, to your own satisfaction with the illness, is bound to have an impact on the child.
And again, it's about keeping yourself open to the idea that actually that is emotional harm to a child, and that is something that sometimes does need to be pleaded, because it's the only way that you're going to be able to deal with the case in a proper manner.
And I think that's most often missed. I think the obvious ones are easy. The obvious ones are easy, where something's been done to a child. I say obvious, they're not obvious, they're covert, and they're very difficult to prove. But they are the least obvious ones. Somebody else fabricating or falsifying for themselves are the most difficult within our arena, undoubtedly.
Great. Before we come on to just talking about some of the examples that we've dealt with, I should say that Dr. Danny Glazer, who is on the link with us and listening to us very carefully, I hope, has indicated that the guidelines that the guidance that you referred to earlier, Tina, has definitely been launched today. And that she is going to do a much more detailed seminar with us in the near future, which is going to deal with the actual condition itself. So we can look at that in a bit more detail.
Fantastic. And obviously we really welcome that, Dr. Glazer, really useful. Thank you. I didn't know. I had looked today to see if anything was coming out, hadn't seen it, so thank you for that. And of course, our slant on this is really the legal perspective, what we see and how we deal with it. And it's just an idiot's guide. If you want the proper stuff, you go to the document I've already referred you to.
Yeah. So we'll let everyone know when that's going to happen.
Yeah, okay.
Future. Right, let's move on to some of the examples, because you're right, Tina. What looks at first glance to simply be a parent who is really concerned about their child because of a medical condition or something else isn't always the case. And that's how we know in these cases.
Yeah. And I sort of sat down as Sharon and I were preparing this, and I thought, yeah, there was the one about. And after about 24 hours, there were about 20 abouts. And I thought, oh, God, yes, there was the one about the lady who pulled out all her toenails, of the baby who was 3 months old and pulled out all the toenails. So of these things we are telling you, not because it's sensational, but it is sensational. We are telling you because we want you to imagine the widest spectrum that you can think of. You know, Sharon and I have done lots of different ones, but those of you who have not done many of these will think, really? Is that FII? And you might also think, by me giving you this list, that all we do in chambers is FII. That is not true. FII cases are like buses. You do 3 in a row, and then you don't do one for 3 years. So let's start. There's the easy to imagine ones. There's the ones like in appendicitis. My child's got a pain in its stomach. My child's got a pain here. It must be appendicitis. Easy peasy. We can imagine that. Repeated attendance at a hospital, repeated attendance at doctors, changing doctors. That's a feature. Have a look for that. And there's a large, moving on to a less easy one, there's a large number of cases with an epilepsy base. My child has fits. My child has grand mal. My child has petit mal. My child does this. My child does that. Nobody witnesses it. They persuade a medic that there are ECGs happen. They persuade a medic that something is happening. Drugs get prescribed. So that epilepsy cases are rife. Sharon and I did one about a lady who convinced the medics for years and years that her boy was autistic. He might have had some autistic traits, but he had a diagnosis of a hypermobility disorder. And this little boy was restricted in a wheelchair, had all the local authority implemented stair rails, bath props, the whole 9 yards of things. And actually, as it turned out, there was nothing wrong with this little boy. There was a very interesting case, that's the Bailey case on Bailey. There's a very interesting case that I think almost everybody in Chambers was in, certainly Ruth Webber and Pauline Troy and Jonathan Bennett and I, involving a little baby, tiny baby, 8-week-old baby. This is, again, on Bailey, Miss Justice MacDonald, who was being poisoned by his parents 3 or 4 times a day with vodka being put in the bottle. The parents tried to persuade the medics that it was hand gel, because they were hand sanitizing so much. It was alcohol in the child's blood. This little boy, I think it was a little boy, had something like 17 life-threatening events in 3 weeks. This little boy so very nearly died. And it took the instincts and the insight of a wonderfully brave doctor, and it's usually the great Ormond Streets and the Evelinas, to put their neck on the line and say, do you know what, this is just not right. This just does not feel right. And she did that, and I think got quite a hard time from her colleagues, but she sent off the bloods, and lo and behold, this poor little boy was full of vodka. So that was an unpleasant one, but out of the range of most people's experience. And it's out of the range of our experience because it's counterintuitive that any parent would do any of these things to a child. So my list goes on. Endless cases of contamination of lines, whether that's nasal gastral tubes or intravenous lines, with either blood, often menstrual blood, or salt to poison the child. Cases where parents, and I've done a couple of these, and it's an odd one, but I think it's quite a feature, push a pen into the back of the mouth of the child, causing blood from the back of the mouth. Again, Katie Phillips and I have done one in front of Mr. Justice Baker, as he then was. They are so counterintuitive. Why would anybody do it? So why would a doctor look for it? So it takes a really savvy doctor to say, something is not right. An FII needs to be included in my differential diagnosis. Lots of suffocation cases, I'm afraid. Philip McCormack, Fawzia King and I did one last year where a tiny baby in hospital was repeatedly attemptedly suffocated, either with a breast as he was being fed or with a hand to occlude the airways. I've mentioned the one already about the mother rolling on top of the baby and killing it. Sometimes bed linen. Several members of Chambers have been involved in a bed linen asphyxiation case relatively recently. One is quite an interesting one. And again, very lateral thinking here, very different. How did the local authority think of this? Gemma Taylor and I were involved in a case a couple of years ago where my client was accused of inducing a different gender in a child. It was actually 3 children, but causing that, imposing upon them a different gender. So FII from a completely different perspective, not a medical one, but yes, a medical one. So that again had an interesting conclusion. But I mentioned those things really briefly to illustrate to you how difficult it is to predict what field, what kind of thing. Yes, you've got your appendicitis, but you've also got a mother alleged to have tried to change the gender of a child by making that up. So really wide-ranging, Sharan.
Yeah, really wide-ranging. And again, important to keep an open mind.
Both ways.
Yeah. Okay, can we come on now then to things that we as advocates and representatives need to be looking at?
Yeah.
Let's look at the most difficult things if you're acting for a local authority. What are the things that we need to be looking out for?
When somebody says to me, Miss Cook, got this 12-week FII case, do you want to do it? I think, oh God, no, please. They are so difficult. They are so time consuming. They are so labor intensive. They're also quite fun and quite satisfying. They are incredibly difficult to prove because, again, think about the counterintuitive point. Why would anyone do this? And how on earth, when these are covert actions, almost always, maybe wanting to be caught, who knows, but almost always covert actions, how the hell do you prove it? As I've mentioned, very often closely observed in hospital and reliant upon that medical team, including in its diagnosis, this differential of FII. It's the diagnosis often of exclusion. We've been through everything, we can't work it out, something's not right, we smell a rat. And it's why it's so difficult. It depends on that one. Sorry, Sharan.
Right, I've been reminded by Susanna Hargreaves, who's joined in tonight, that of course when you referred to medical chronologies earlier in the discussion,
yeah,
which is so important so very early on, there are companies that will prepare medical chronologies.
Yeah, there are, but one, I don't know how the medics look at that. I don't know whether that satisfies the guidance of the Royal College of Paediatrics. I'm not sure it does, because for my mind, one, they don't know what we're looking for. They don't get the nuances unless it's a medic or a lawyer doing it. They don't get yes, of course, anyone. My 15-year-old could do a medical chronology for me, but they don't get the nuances. In fact, an 8-year-old could do it. Anyone could do it. It's knowing those nuances. It's knowing what you want to get out of them. It's fitting all those things together at the end of the day, that in fact is what does it for you. I mean, the case you and I did, Sharan, I think had a shop bought medical chronology, and did we use it? No, we did our own.
No, you're right. We it was a very, very detailed document.
Yeah. And if you wanted a page number, yes, it was fine, but otherwise it was pretty useless. So there's no substitute for reading the papers and doing your own chronology, I think. And there's also the necessity to call a lot of witnesses to prove these cases, whole wards of nurses to say, I did see or I didn't see. So it's really hard to, as a local authority, to persuade your hospital to give up all those nurses and doctors to come along for a 3-week hearing.
Yeah.
So there are, as a local authority, endless difficulties.
In fact, Dr. Glazer's just reminded us as well that any medical chronology needs to be very clear in differentiating between who's actually observed the event, if there has been somebody, or whether it's a parent, carer, as well as who reported, because those can be 2 different things sometimes.
Oh, completely. And so much hearsay. a case I did last summer with Philip and Forzia, which was an asphyxiation case. We had hundreds of, we didn't, that's an exaggeration. We had tens of nurses, and we were trawling through the records because it wasn't clear. The mother was saying, I'm just anxious about my baby. I haven't caused any harm to the baby. And trawling through those records to find out, is it first-hand information? Did the nurse witness it? How far away was the nurse at the time? Who's recording it? You know, it's very difficult. It's very difficult. And, you know, you and I, Sharan, know what we're looking for. And that's why a shop-bought chronology, in my view, for me, is a waste of time.
Now, representing a parent.
Proving a negative. You've got to prove a negative. I mean, how unpleasant is that? You know, you come along and you're proving that you haven't done it, and it turns on the head the burden of proof. It's for the local authority to prove. Well, here you are as a parent saying, you've said I've done this. You've said I've contaminated the nasal gastric tube, and I'm not going to prove I didn't. So the most important thing for me, for a parent, is how on earth am I going to prove this negative? Yeah. There's also, as I've already said, a huge amount of paper. So you've then got to trawl through, and usually a huge schedule. I mean, I don't really agree with huge schedules, but often when you are for the local authority, there is so much information, you have to get it in, and it is that jigsaw. It's that jigsaw. It's not just the 3 salient points. And we all know judges who say, I want your 3 best points, and that's all you're going to put in. It's not those 3 best points. It's what's happened over the last 6 years in 7 different hospitals for this child. And it's not your 3 best points. So volume of papers, and again, access to medical witnesses. If you're trying to prove a negative, it's the Dr. Glazier point. You need to be able to know who saw, who recorded, what was witnessed. And very often, until you've got them in a witness box, you don't know that. Whereas at least the local authority has access to those nurses and doctors and can ask them the questions. I know there's no property in a witness, but much more difficult for a parent to go to those witnesses and try and find that information themselves. So I think those really, most of all, the proving the negative for me is I find very tricky when I'm active for a parent.
Yeah. You're right. It wasn't an FII case that I dealt with now 2 years ago, Easter 2 years ago. It was FGM. The local authority were alleging that the father had carried out FGM on his vulnerable wife, very vulnerable wife, with his sister. The difficulty was that the medical evidence showed that the mother had undergone an FGM procedure at some point. And it wasn't until Alison Pryor and I had an extremely detailed look at the medical evidence. I mean, pages and pages of documents that we
and again, Sharan, not just once. You look at it the first time and you pick something out and you think, yeah, that's benign, or that's important. And you look at it again in the context of the other parts of the jigsaw and you think, how did I miss that?
And often you're right, you go back and you look at an event or a comment that on its own means nothing. But when you look, when you know what's in the rest of the papers,
exactly. And you wake up in the middle of the night and you think, there was something. And I know it was a right-hand facing page, and can I find it? So there is all that just experience and reading the papers and looking at them again and again.
Yeah, not so easy with a digital bundle, I have to say.
Wow.
But you're right, it's the trawl through that is so important.
It is.
Right, Tina, we're going to have to draw things to an end. But before we do, can I just have a look at some of the tactics that we ought to keep in mind?
Yeah, I think I've mentioned them already, Sharan, really. No substitute for reading the medical records time and time again. Brilliant chronology. You and I both know we do something called a prep doc. You put all those streams of consciousness in one document and you keep going back and you keep looking at it. So tactically, you just have to keep going over the same ground and working through it in a very sad way that sometimes we quite like. We've got to remember we do get paid for reading the papers, so that's quite a bonus. And there's the jigsaw, and there's looking at the instincts of the medics. Look at those medics, the nurses very often, and the doctors in equal measure, who are the ones who alert you, and go back and say, Why did they alert? What rat did they smell? And borrow their instincts and follow that through. So I think really look at the jigsaw, look at what the medics were doing, and just read the papers again and again and again, and you will get it. And also open mind, Sharan, you said open mind. It might be the anxious parent.
Yeah.
It might be the anxious parent.
Yeah. Tina, thank you. We ought to just say, lastly, that having referred you to the guidance, you should also look at the very important case of REX. There will be the links to the cases that we've referred to on the Chamber's website in the next few days. Tina, I know that you would also wholeheartedly recommend that those judgments are really important reading. So,
yeah, really important and interesting, actually.
Thank you.
Thank you so much, Tina and Sharan. In fact, Sophia Pariah has asked specifically for the citation that you mentioned of the case involving hypermobility and autism, because it sounds just like a case she's got at the moment. So Sophia, we've noted that, and the citation will be put up.
Yeah.
Anne-Marie Rainsford has asked, do you have any advice for the type of situation where you act for a child or other parent and believe that this FII is a real element to the case, but that the LA are opposed to identifying it as FII, probably due to the difficulty in pleading it in threshold?
Well, if you're for the child, you can, of course, introduce it by asking for your own schedule. I guess you've got to have the leave of the, or the cooperation of the court, not the leave of the court. I have certainly acted for children where a guardian has been more enthusiastic about an FII aspect of the case than other people have, and either by discussions with the local authority or by really producing their own schedule and say, this is an issue, we need a single joint expert, in advance of the schedule. It's actually, if you have a pediatric overview anyway in a case, which very often you do, it's one question. It's one question to that single joint expert. So you as a child, and indeed for a parent or a carer who's not the subject of the FII, can put that in. And even if people don't really approve of it, it's one question. You can get one question in very easily.
And the difficulty is, Tina, that if you don't deal with it in the letter of instruction, it's going to come up in your prosecution.
Exactly, it's going to be there. And actually, you're not fulfilling your professional duties if you say, oh, well, there we are, someone else will deal with it. You've got to deal with it head on. Just deal with it.
There are other questions, but we're running out of time, ladies. There's just one final question, which is a bit of a catch-all, which is certainly the experience of all of us, because this comes up on the Chamber's intranet all the time. What about the dearth of experts in FII cases? I find personally there's a dearth of paediatricians who are really good at it, and also a dearth of psychiatrists who can then go on and advise later. So dearth of experts, tips please and help. And the other matter we've been asked about is pointers on good letters of instruction. I think you've already dealt with that, Tina.
Shall I start with the experts, Sharan, and you can pick up on it if you disagree with me? There are 2 or 3 psychiatrists who I would go to. Whether you want a psychiatrist and at what point depends on whether you're for a local authority or a parent. If I was for a local authority and I could get away with it, I would always have a psychiatrist at the beginning. If I was a parent, I would resist it violently. Pediatricians, I completely agree, Gemma. There are consultant pediatricians who do a very, very good job of this. And there are those who don't. Dr. Kate Ward, who is no longer working, I don't think, used to do an amazing long report on it and was very balanced. I don't think she'll do anything anymore, which is super sad. But it's difficult. I mean, it's really difficult because it's a big, big piece of work. And by the time they've done the hours, the Legal Aid Board are saying, we're not going to pay for that. And it's a lot, as we all know, it's a lot of hours.
And asking around, asking colleagues for recommendations. There's no substitute for that, I find.
I'm going to wrap it up now, ladies. Thank you very much indeed for this introductory talk, I'll call it, to FII. And thank you very much indeed as well to Dania Glazer, who has been contributing on the sidelines, reminding us that, of course, FII is not just about physical abuse, it's about emotional abuse and medical neglect. It covers the widest spectrum of harm, which makes it so fascinating to deal with, putting our clinical hats on, because there's such an amazing interaction between the medical and the mental health issues. We are going to be having more seminars. We're putting a seminar program together. Immensely grateful to Dania Glazer for contributing even before this started and during, and for agreeing to come back and hopefully come back soon to kindly tell us more about the new Royal College of Paediatric and Child Health Guidance, which I notice has a different title. It's got Perplexing Symptoms and Fabricated and Induced Illness, which is fascinating. So for us to have a bit more insight and guidance about that will be great. So please watch this space. We'll be having, that is certainly one of the talks coming up very soon. We also have talks planned on the Court of Appeal judgment when it comes out on the conjoined domestic abuse cases, and also another one about financial remedies. I'm reminded I'm not remotely techie, but even I can do this. If you go onto our Chamber's website and you want to see any of the talks which we've already done, because they're all recorded, we have our own YouTube channel. So for those that want to top up their CBPD points or remind themselves of what they may have missed because they're out making a cup of tea or something else, please remember to use that YouTube channel. And thank you very much for joining us. I'll say good evening. Goodbye.
Good night.